This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub Podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Elara, Research Fellow. Today, we're looking at a fascinating new study from the Journal of Neuro-Oncology, published in 2026, titled Optimizing the Stupp Protocol for Treatment of Glioblastoma, Eliminating Age Bias, Enhancing Treatment Timing, Use of Stereotactically-Guided Sequential Boost, and Dexamethasone Dosing.
This is a paper that really hits home for those of us in the OR and the clinic. We've been using the Stupp protocol, radiotherapy with concurrent and adjuvant temozolomide, as our standard of care since 2005. But as the authors, Sharp and colleagues from Houston Methodist, point out, the implementation of this protocol in the real world is incredibly inconsistent.
Exactly. And what's interesting is that the original Stupp trial actually included a heterogeneous population that wouldn't even meet our current 2021 WHO diagnostic criteria for glioblastoma, particularly regarding IDH status. This study specifically looked at 269 patients who met those modern criteria, IDH wild type, no 1p19q codeletions, to see how we can refine our current approach.
They focused on 5 critical questions, but I want to start with the one that challenges our daily clinical bias: age. We often see patients over 70 and hesitate. We worry about frailty, or we offer abbreviated radiation courses. What did the data show there?
This was one of the most striking findings. The study found that patients aged 70 or older who undergo maximal safe resection and complete the full chemoradiation protocol have survival outcomes, both progression-free survival and overall survival, that are virtually identical to younger patients.
That's a powerful statement. It suggests that age alone should not be a contraindication for aggressive therapy. If the patient can tolerate the maximal safe resection and the subsequent CRT, they derive the same benefit. The authors explicitly call for the elimination of age bias in treatment selection.
Right. The decline in survival we often see in older populations in other studies might actually be a result of undertreatment rather than the biology of the disease itself.
Moving on to the win of treatment. Timing is always a debate in our multidisciplinary boards. How soon is too soon, and how late is too late to start chemoradiotherapy after surgery?
The study identified a specific sweet spot. For patients, particularly with MGMT promoter methylation, initiating chemoradiotherapy between 32 and 49 days post-surgery was associated with significantly improved outcomes.
32 to 49 days. That's roughly 4.5 to 7 weeks post-op. It makes sense intuitively. You need time for the surgical wound to heal and the blood-brain barrier to stabilize, but you can't wait so long that the residual macroscopic disease begins to proliferate unchecked.
And the paper highlights that this timing, along with the completion of the protocol, significantly improved OS in both methylated and unmethylated populations. But they also dove into a specific technical modification of the radiation itself, the SGS boost.
Stereotactically-guided sequential boost. For the residents listening, this is an additional dose of radiation targeted specifically at the tumor bed. What was the impact there?
The benefit of the SGS boost was most pronounced in the MGMT methylated group. The researchers found that adding the sequential boost independently improved outcomes in these patients. It seems that if the tumor is already sensitized to DNA damage because of the methylated MGMT status, that extra targeted hit from the boost really moves the needle on survival.
Now let's talk about something we all prescribe but perhaps don't scrutinize enough: dexamethasone. We use it to manage perioperative edema and radiation-induced swelling, but it's a double-edged sword.
It really is. The study found that dexamethasone exposure is a major predictor of poor outcomes. Specifically, they looked at a threshold of 1.2 milligrams per meter squared of body surface area. If patients were receiving doses at or above that 1.2 milligrams per meter squared mark at critical treatment points, their survival dropped significantly.
And those critical points included the final week of chemoradiation and during the adjuvant temozolomide cycles. The paper mentions that managing edema with dexamethasone may paradoxically worsen outcomes due to its immunosuppressive effects.
Exactly. It's a bit of a catch-22. We use steroids to treat the symptoms of the tumor and the side effects of the radiation, but by doing so, we might be hampering the body's immune response against the glioblastoma. The authors suggest that we need to be much more aggressive in tapering steroids, aiming to keep them below that 1.2 milligrams per meter squared threshold whenever clinically possible.
It's a reminder that every milligram of decadron has a cost. For a standard-sized adult, 1.2 milligrams per meter squared isn't a lot. That might only be 2 milligrams a day. We often see patients on 4, 8, or even 16 milligrams for extended periods. This study suggests we are likely overdosing them to their detriment.
To summarize the multivariable analysis, the timing of the steps, the use of the SGS boost in methylated patients, and the strict control of dexamethasone dosages were the keys to optimizing the Stupp protocol.
They also touched on the number of adjuvant temozolomide cycles. The standard is 6 cycles. Some clinicians extend it to 12. Did they find a clear benefit to doubling the duration?
While they examined the extension from 6 to 12 cycles, the core of their optimized protocol emphasizes the importance of the initial phases, the surgery, the timing of CRT, and the steroid management. The data reinforces that completing the standard protocol is the primary driver of success, rather than necessarily extending the maintenance phase indefinitely.
This paper is a call for precision in how we execute what we already know. We don't necessarily need a new drug today to improve glioblastoma survival. We need to be better at timing our radiation, more targeted with our boosts, more disciplined with our steroid tapers, and more inclusive of our elderly patients.
It's about refining the standard of care into a precision of care. For the residents and students listening, the key takeaways are: don't rule out a 75-year-old for full treatment if they are functional. Aim to start CRT around week 5 or 6 weeks post-op. Consider a stereotactic boost for your methylated patients, and get those steroid doses down as fast as safety allows.
Well said, Dr. Elara. This study provides a roadmap for incremental but significant improvements in a disease where every month of survival is hard-won.
Thanks for joining us on the Neurosurgery Hub Podcast. We'll link the full study in the show notes.
Until next time, stay sharp.